Never have we found ourselves following such strict mitigation measures around the world. In mid-March, when a large percentage of the U.S. population, where I'm currently based, went into lockdown to shelter in place, similar orders and guidance were given to our colleagues and partners from Kenya to Nigeria, within Asia and Latin America, and throughout Central, Eastern, and Western Europe. How we are working together has quickly shifted to a global virtual reality, while at the same time the needs of the millions of communities where we work around the world have not changed. Our aim today is to showcase some of the most creative and innovative approaches being adopted in real time to prepare and respond to the many needs of our partners around the world. Our goal is to identify creative solutions to ensure that those who are most vulnerable get the support and services that they need. Our collective role is to provide country-level governments, NGO program managers, healthcare providers, and community health workers on the ground with the access to the best information and training possible so that they can adequately care for and support the communities where they work at this critical time. I'm really pleased that we have such a great group of presenters to address these issues today. And David, if you could advance the slide, please. Thank you kindly. So I want to just very quickly go over the agenda with you. The format for today is that we will be having 4 presentations. We like to do 2 presentations and then pause for discussion. And then when we pause for discussion, David will be putting forth a polling question, and we'll tabulate the results and provide that to you after the pause for discussion. And then at the end, before we close, we like to highlight some key resources, and our presenters will also be highlighting resources as we go. Next slide, please. Okay. So I want to quickly present give an overview of the presentations before we start. Today we have Carla Sanchez with us, who's the Senior Specialist for Behavior Change and Community Health with the READY Initiative for Safe Children. She will frame the overall coordinated response approaches and resources for COVID-19. She will be followed by Tom Cotter, the Director of Emergency Response and Preparedness for Project HOPE, who will present healthcare preparedness and response training, a really new and very great model that they have. After the pause for discussion, Ambretta Baggio, the Senior Advisor for Community Engagement and Accountability for IFRC, will discuss mainstreaming RCCE in the overall response to ensure continuous learning and co-creation with communities. And finally, we are very happy to have with us Eric James, the Executive Director of Field Ready, and his colleague Claire Louise Tavers, the Global Impact Lead for Field Ready, who will outline innovative approaches to 3D options to meet immediate country-level needs in real time. So again, thank you all for joining. For those of you who have just joined, please put your name in the chat box, the country from where you're from. Please feel free to ask questions throughout the presentations. We'll be pulling the questions for discussion, and we've asked our presenters to actually engage with you as well. To start it off, before we ask the first presenter, we just want to give you a focus question, and that is, what is the most creative approach that you or your organization has adapted, to respond to COVID-19? All right, so again, thank you. And with that, I will hand it over to Carla Sanchez and ask you to please take the reins. Carla?
Thank you so much, Julie. And hello, everyone. Good day, wherever in the world you may be. Happy Friday. I'm sure we can all use a well-earned rest weekend. So as Julie mentioned, I am Carla Sanchez. I am the Senior Specialist for Behavior Change and Community Health with Save the Children on the READY initiative. And just a little side note that I am on the READY project, but my focus is kind of tailored towards risk communication and community engagement. And I will try to do my best to answer any other questions that you might have. And if I don't, then I will consult with the team and get back to the core group to share that information back with you. All right. Maybe at first I'll provide just a quick introduction as to what the READY initiative is. It is a 3-year OFDA-funded consortium project, so 2018 to 2021. And what we are doing is augmenting what already exists to build NGO capacity for infectious disease response. So that could be, major epidemics and even global epidemics like the one we are facing right now with COVID-19. Our 3 primary objectives include to improve NGO coordination, to strengthen operational capacity, and to adapt and develop technical readiness. And our READY partners, well, the project is led by Save the Children. We also are partnered with Johns Hopkins Center for Communication Programs and Center for Humanitarian Health, UK Med, Mercy Malaysia, and EcoHealth Alliance. Whoops, wrong button. Okay, so why READY? So READY, when we first started the program, we decided that the first step was to do an assessment, a landscape analysis, and a literature review, and consultations and desk reviews, et cetera. And what we found were some gaps in NGO outbreak response, including there were challenges with coordination. There was outbreak response structures that are opaque or inaccessible. Social science interventions are consistently delayed, under-prioritized, and under-resourced. Inadequate multi-sectoral integrated response, and unused outbreak preparedness plans in a lot of cases. And this has become very we've recalled this now during the COVID response. So some of the COVID activities that READY has taken out, has endeavored on, include COVID-19 readiness workshops. We did a global workshop in London in December 2019, and this was, of course, December at the time of COVID. However, the global community wasn't really as aware of this yet. But we did kind of focus on our kind of pan flu and the possibility of an upcoming pan flu epidemic. So we also have done some regional workshops between March and April in Western and Central Africa, Eastern Southern Africa, and the Middle East. We've done country workshops in Vietnam, Indonesia, DRC. And we have upcoming workshops in Asia, the regional Asia workshop, Bangladesh, Uganda, and South Sudan. And just to note that these workshops are based partly on the literature review that we've done, a lot of the scientific evidence base. They're also based on the WHO response plan. And the workshops are kind of laid out following 3 key pillars, which is FBC and RCCE, risk communication, community engagement, business continuity, and IPC/staff safeguarding. And just, after each workshop, we've taken the information and the lessons learned from each and the information that we've gathered and kind of adapted and modified. In addition to that, we've also, adapted and modified the content and information we're sharing and the information we're trying to gather based on the evolving epidemic as well. And just to say also that these workshops are not just for READY consortium partners, but it's there is interagency representation. And I'll share a little bit more information on the lessons learned about that. We've also supported global coordination mechanisms, including RCCE subgroup on community engagement. And I think some folks here, I'm seeing some familiar names here that are also in the subgroup. We also have others like Working Group for Global WASH Cluster, OIE, GHC, IASC, IMWG, IAWG, and if the acronyms are not familiar to you, I'll be happy to add those into the chat box a little later.
Yeah.
Yep. Is there a comment? Okay. We've also supported the development of global level guidance documents, including one for RCCE on remote engagement of communities in hard to reach areas. We've done indicator work with IMWG. We've also done weekly COVID-19 and humanitarian settings webinars for knowledge exchange and experience sharing. And we have upcoming, we're working on technical training based off of a gap analysis to identify training gaps for an emergency response around multiple sectors. So just to jump back to the workshops for a minute and just to kind of share some of our lessons learned. You know, some of the feedback and information that's been shared in our group work and in our discussions have been a lack of community case management training among NGOs. COVID-19 guidelines are often removed from the actual reality, the lived reality of individuals. PPE best practices remain unclear among NGOs. I recall specifically a discussion, a very large discussion around the use of masks and types of masks. Widespread recognition that IPC guidelines need to be implemented across sectors, and that community leaders are key to addressing rumors and misinformation, and also to building trust with communities. So some of the resources that we have available are, we have a READY website, and I'll put this link to all these resources into the chat box as well, live links, but we have the READY initiative, where we have resources, information, and where we have the upcoming READY discussion forums as well. These are up and coming. We also have an RCCE toolkit, which is accessible on the READY website. And this RCCE toolkit includes community entry, community monitoring, addressing rumors and misinformation, amongst other things. We have an integrated framework that we're working on. We also have operational checklists, which you can also find back in this RCCE toolkit. We have Compass training modules, so we have modules on risk communication, community engagement, on WASH, on remote community engagement, et.cetera. And this is a Save the Children website. And we also have a landscape report from our early assessment. Whoops, again, wrong button. All right, so that's in a nutshell what we have. I'm looking forward to any questions that you might have for me. And I'll hand it back over to Julie. Thank you.
Oh, thank you, Carla. Perfect timing. Much appreciated. All right, let's go right into Tom. Tom?
Hi, everyone. I am navigating. There we go. I think everyone can see me.
Welcome, Tom. All right.
First of all, thanks very much for having me. I just scrolled through the participants. It's really nice to see a lot of friends and colleagues and even classmates in some cases. So appreciate being able to share a little bit about Project Hope, our work, our lessons learned, and where we're hoping to go next. So my name is Tom Cotter. I'm the Director of Emergency Response and Preparedness at Project Hope. And this presentation is one aspect of our global emergency response strategy for COVID-19, and what I really wanted to convey here is obviously an enormous part of something like this, just like we heard from the READY initiative, is building capacity at the local level. And so going into this emergency, Project Hope really wanted to do that, had to develop new strategies based on the scope of this. So I'll go right into it. So if you don't know Project Hope, we're a global health NGO. We're based in Washington, D.C. We're not an emergency response organization. We're a global health organization that does emergency response. We have offices in about 12 countries and certainly partners in a lot more than that. Our programs focus on capacity building, even our emergency response programming. Certainly we do medical teams and gift in kind, but at the end of the day, we really enjoy healthcare system strengthening through capacity building. So I want to go really quickly through our own personal organizational timeline with the pandemic. In some aspects, it's a little unique because, well, we found ourselves on the front lines really early because we actually have a country office in Wuhan. So we started responding when there were 200 confirmed cases in China. So in some cases, we started thinking about this and started developing a strategy as really early. So in February 2020, we had, by that point, successfully been able to import into China, which was also unique, I think, for an international NGO to be able to do. And then later in the month, we started to develop our global strategy. So we sent word to all of our country offices, all of our regional directors, all of our program staff saying, we need to start thinking about how we need to reorganize ourselves, shift our focus to add aspects of this pandemic response into our programming when we started to see where this was going. So we really did restructure from the ground up from a global health development organization to a pandemic response organization, and identifying what critical components of our programming needed to stay, and figuring out where we can augment or alter our programming to suit sometimes both the original objectives, but also the new objectives of preparing folks for COVID. And then in March, seeing a gap here, we developed a readiness and response training curriculum. And I'll talk a little bit about the curriculum and how it's different from some of the things that are out there already. We also, in March, reversed the supply chain, and we started being a net exporter of PPE from China, and found a lot of partners there. And reversing that supply chain was key to that was our presence on the ground in China, where we could negotiate in Mandarin Chinese, for example. We could identify and do quality control testing in China on products. So we found that to be very, very useful. In April last month, which feels like 10 years ago, our training implementation for the curriculum is fully underway, and I'll go into that. We've deployed response teams in the U.S., and nearly all of our global programming has adjusted to meet needs for the COVID pandemic. So I'll go into the training. I'm going to focus on that for this one. But just a little bit, I want to start with kind of by the numbers first. As of right now, we've trained over 15,000 healthcare workers and frontline personnel. And we have had our content downloaded. Additionally, from that, our content's been downloaded about 350 times. And then there's some PPE numbers there that I won't go through. So here's what the training outline is, and this is what I think makes it a little bit unique, because we wanted to make a more comprehensive program, which of course has its challenges too, because it's longer. But we go through an introduction of the virus. We go through IPC, surveillance, patient treatment, diagnosis. The management of severe illness and acute respiratory failure was a module that we designed for primary healthcare providers, should they be needed in an ICU context or be needed to take care of a patient in acute respiratory failure. Screening and triage, how to surge your healthcare facility, how to augment or change your operations, and then into risk communication and public health messaging, including things like social stigma, lessons we learned from Ebola and other disasters and epidemics. And I've lost my mouse. Here we go. So the unique challenges that we found right away is that this is not going to be our typical training environment where we can dust off the binder and get the slides refreshed, add some new logos to it, and refresh pictures and implement it. This is not going to work. We have to figure out how to train remotely. We have to figure out how to train a lot of people. And it needs to be, we can't have a one-size-fits-all training program because one size is not going to fit all. So is there any use in trying to do this, I think, was the initial conversation with these challenges. And we opted into it. We leaned into the challenges, and I'll talk about how we did that and some of the challenges that remain. So in terms of remote delivery, when we initially partnered with Brown University. They have a Center for Health and Humanitarian Law, Humanitarian Rights and Law that specifically does this with Dr. Adam Levine, who's a subject matter expert. But this was planned to be an in-person training. We had to abandon that idea almost immediately as it was being developed because, of course, the travel restrictions started to come to light. And what this meant was we were essentially cutting off an enormous subsection of people, because now our participants need to have reliable electricity and internet. We've introduced time zone issues because our presenters would all be in the U.S. and all of them are also active clinicians, all of our master trainers. So they're seeing patients, so they can't just adjust to do a presentation at 4 a.m. Translators are not really practical in remote training. They're a bit more practical in live training. So all of our trainings had to be in the language in which we could find presenters that were fluent in. And obviously the IT challenges. Even in this presentation, the core group was wise enough to do an IT check before kickoff. And And we found that to be very, very important. However, here's the benefits of it. Trainings are very cheap now. We're not flying a bunch of instructors around the world. We're not getting a venue. We're not paying for lunch and things like that. So these are a lot cheaper now to conduct, which means we can do this more. We can easier record the seminars themselves. So if we have a 4-day or 5-day curriculum, if someone misses a day, we can send them the video, and that's really easy. And they're faster, frankly, because there is no travel time. So while we're thinking about the rollout of this training, our objective, beyond making sure it's a quality thing, we recognize the need to hit as many people, to get this in front of as many eyes as possible. And we were going to have to sacrifice on our way there to make sure we hit that objective. So right away, we had a training bottleneck. The master trainers, they were great. They were fantastic. They were the highest quality, but they had limitations to their availability. So we were only able to do 2 trainings a week. This was not going to work. So we had to create more trainers. So we developed not only this train the trainer model, of course, where our trainers would train a cohort that then would go out and do cascading secondary training, but we also developed a regional rollout model where Project Hope is organized into regions between Africa, Southeast Asia, Europe, Latin America, and Caribbean. We put a team and a coordination function in each one of these so that now regionally they can coordinate their own trainings rather than them all coming from the East Coast of the US. In countries where we don't have a Project Hope office, this is a bit challenging. Where we did have a presence, we could identify specific individuals that we wanted in our original cohort that we knew would go forward and train. But if we're not in a country, we had to find a partner to do this, and we had to find really reliable partners. And I think what that speaks to is the new reality where we're really going to have to decentralize a lot of our emergency response activities and a lot of our programming in general. But these partners that we found, they were responsible for identifying the participants, coordinating the times of the participants, and then either promoting or supporting in some way the secondary cascading trainings. And then what we were asking back is data on this. How many people did you train? Do you have any feedback? Do you have data on the pre and post test for this? But in these cases, especially for the secondary trainings, we provided not just the PowerPoint slides, we provided a full instruction manual along with videos and translated materials. But this still wasn't enough for us. We still wanted to reach more people, so we made the decision just to release the materials. Here's the PowerPoint slides, here's the manual. I'll put the link in the chat right after this, but anybody can go in and download this. There's a really quick registration. We keep track of who's getting it. If it looks like they have no business getting this at all, we ask them a couple follow-up questions. This gives us a lot less control over what happens with the material, frankly. We release it in PDF, so there's only so much editing you can do. But really, we really wanted to get the broader reach. And so that was a trade-off we had to be okay with and a decision we had to make. And so the other problem was contextualizing the training. One size is not fitting all. So the TOT model, when we're teaching this as a TOT, we're encouraging the new trainers in the initial cohort to modify this. And the way we're doing this is encouraging a lot of Q&A. So each time we do this with a different cohort, we have a lot of discussion about the specifics of the healthcare systems and where these new instructors are. And that allows a lot of localization of the material. We've also modularized the curriculum because we want instructors to be able to say, here's an audience that only needs these 3 things. Or we want partners to say, this is great, but we only need these couple modules here. And we also translated the materials. And we found that was really useful, and the discussion brought forth a lot of things. So even though the bullets on any individual slide might not change, but the way the instructor presented in their own speaker notes based on the Q&As in the original TOT allows for a lot of customization there to make it fit the context. And we had to find hybrid teaching opportunities. We had to find innovations where we could. So sometimes we had to combine just the videos with follow-on sessions that promote those discussions. We're putting this into an e-learning context. We're working with Disaster Ready, for example, to modify all of our content to make it mobile and mobile friendly and low bandwidth friendly. so that anybody who wants to self-learn rather than be a TOT type training, they can look at this, and that's starting to roll out in the next 2 weeks. We're also partnering with folks at Project Echo and Project Echo hubs to incorporate this training curriculum with case studies and care consultations. And this is really important because the science is going to continuously change on this. There will be continuous, complications and complex patient cases that, our cohorts and our instructors and the people who are the end users of this training, frontline healthcare workers, will want to communicate. And so we're collecting that through Project Echo. And if you don't know Project Echo, it's a really nice thing. I won't touch on it here. It's a bit outside the scope, but I do encourage you to take a look. So these are a bit of our innovations in ways that we're modifying our training for the future. So currently, this is, the challenges of this is that this was not, we created the training and then we're done with it, because we're constantly having to be on our toes. Part of it is that, as I mentioned, the COVID information is constantly updating. So we have to keep engaging our SMEs to refresh the content and making sure that the refreshed content is pushed out to the extended network and pushed out on our website, pushed out to all of our trainers. We're developing additional curriculums and modules based on gaps that we're finding and needs that we're seeing from our partners. The first one of which is a community health worker, COVID practitioner. And that presents its own challenging because CHWs mean a lot of different things. They're a very broad scope of work. We're also looking at healthcare provider mental resiliency, and again, using our existing infrastructure to mobilize these modules. And then as vaccines come on, we'll add more content around that and figuring out how we can support governments and entities with contact tracing and providing training on that. The other thing we're doing is building our own internal resilience, planning for the upcoming hurricane season and having a lot of conversations about that. How can we leverage the networks that we're having? How can we change the modules, or how can we use the infrastructure to be one of the tools in our portfolio for hurricane season? And then we're building an additional LMS capability because we recognize once we give someone a PowerPoint, we don't have a lot of control there, but if we modify the way in which we present, we hand off the material, we can provide a bit more standardization, a bit more control there. I won't go too much into that, but there are some softwares out there that we're looking at. And that's it. Really appreciate it. I'll put the link to the training inside the chat, but I appreciate your time and your questions.
Thank you so much, Tom, for that presentation, and also thank you so much, Carla, for your previous presentation. As we said at the beginning of the call, we will be also using a polling option on WebEx, so we can get some information about what you think about these issues right now. So I'm going to launch the poll now. You should be able to see this, and we will show the responses in a couple of minutes.
Hi, David. I'm back.
Yeah. Thanks, Julie. Go ahead.
Thank you so much for setting up the poll, and thanks everybody for participating. The first thing that I want to do is the question that we had is we'd love the speakers. This is for Tom and Carla. We'd love the speakers to address getting info and safety equipment and training to congregated settings, orphanages, psychiatric institutions, assisted living, etc. So the question is, what is your experience or capacity to address the PPE needs for those with special needs? Tom, do you want to start with that?
And remember to unmute yourself, Tom.
Maybe, Carla, we could ask you if you could respond.
Yeah, would you mind just repeating the question again, please?
Yes. The question was, there was a request to have the speakers discuss about getting safety equipment and training to settings where with people with special needs, orphanages, psychiatric institutions, assisted living, etc. So this idea that if we're working with the general community, is there a focus in your program to actually focus on those with special needs? Over.
Thank you for the question. So firstly, the READY initiative is not an implementing organization. What we are doing is kind of creating information sharing and communities of practice and stuff like that with our partners and NGO partners on the ground. That said, we do have, for example, with our workshops, like I mentioned earlier, we are adapting and modifying based on the needs and based on the requests and the considerations from the participants, participating NGOs. And some of these have focused a little bit more or requested to focus more on more vulnerable populations, which does include the people with disabilities, orphanages, and prisons, et cetera. And so we've kind of shifted a little bit our kind of work and considerations and possible suggestions for activities and how to reach these target communities specifically. Using whatever resources or communication channels that they're using with these populations. So we're providing resources, guidances, information, and also collecting what other folks are doing on the ground with these populations to kind of create that discussion.
Oh, that's great. One of the things earlier, Carla, in the chat box, you were talking about the coordination with other initiatives. And I would just like to ask you, if you could expand coordination based on where you are now and the learnings that you have since December, or if you could expand coordination, where would your focus be? Over.
Well, I'm a little biased because I am a community engagement person and an SBC person. So if we could expand coordination, it would definitely be around RCCE. Right now, there is a very high need for that, and I think that governments and countries are also realize how important RCC is, and there's kind of a shift towards that, and kind of just creating a bigger kind of global network of RCCE practitioners, I think would be kind of one of the key things that we could be doing.
Well, thank you for that. Tom, I'd like to, we had a comment for you, and it says, thanks, Tom, for the presentation. I want to ask how your trainings were conducted in Wuhan to healthcare providers. Was it physical face-to-face or virtual?
It's a good question. All of our trainings globally right now are all virtual at the first level. And I talked a little bit about the challenges of that and obviously the reasons why is we can't fly instructors anywhere. But what we're finding is a lot of the instructors in the initial cohorts in which we're training in the Train the Trainer program, they're going out, and some of them are doing virtual, but some of them are doing social distancing appropriate in-person trainings for individual hospitals and things like that. So even though our initial strategy is virtual, they are trickling down into places where they don't have reliable internet and electricity, which is exactly what we want to see.
Thank you for that. Now, if I could just kind of follow on with another question for you, Tom, I'd like to, there's one question about resistance and ministries of health, and what I'd like to do, if the questioner would allow me, is to flip that. And what I'd like to ask you, Tom, is what is working? And specifically, let's build on that. Could you speak to coordination efforts with ministries of health in the countries where you work? And can we focus a little bit on what's working so we can turn the resistance around a little bit and build on that?
Absolutely. One of the great benefits of an organization like Project Hope, and why I really specifically mentioned us as a global health organization rather than an emergency response organization, is that our long-term presence in these countries allows us this access and allows us the reputation and trust of these ministries of health. We're fully leveraging that. We're using whatever professional capital we have to do these trainings. That being said, we're also finding other partners at the same time. Once we get the blessing, we're reaching out to healthcare facilities and even other NGOs, especially, as I mentioned, in countries that we don't have a presence. And so coordinating with them on that. We're also looking at, we're leveraging relationships with the CDC, the Africa CDC, to get this on a platform and actually have trusted agents, even like USAID, to introduce us to the members in the Ministry of Health and to advocate for this training, and that's been working quite well.
Oh, that's great. Thank you so much.
I want to pick a question out, and I'll just run with it if that's okay. There's a couple questions about assessment, feedback, mentoring, and ways that we're requesting evaluations, which is a big part of this. And I mentioned one of the trades-off of having casting the widest net possible is we lose a little bit of that data, and that is a sacrifice we very purposefully made. We're not in love with that decision, but it was a decision we had to make. That being said, in every package, in both in terms of if you just download the content from our website, but also if you're in a cohort and attain a live training, virtually, you get pre and post tests, you get feedback forms to then administer down the line and provide that feedback to us. Right now, I mentioned an LMS, a learning management system is an LMS that we want to convert all of the kind of PowerPoint and Word documents into. It will automatically ping people for that feedback and for the pre and post test. And kind of the sneaky thing is that we're also incentivizing it by withholding certificates of completion until we get that evaluation. And so it's going to be a little bit of an easier way for us to automatically get that evaluation. But it is certainly tricky based on the scope of the project.
Thank you, Tom. I'm back. I'd like to just ask one more question to Carla, if I could. We had a question, Carla, about how is impact measured?
Yeah, that's a great question. So, and I kind of have to bring it back to, we're not an implementing partner, and actually we're not tracking these activities that the countries are doing. We're kind of creating that coordination and the networking and sharing of information and experiences learned. But we are personally, as the Ready team, are not tracking this kind of information. So I wish I could have a better response to impact. But yeah, that's not necessarily what we have been doing or aiming to do as Ready.
Well, thank you for responding. It's interesting, isn't it, when we're looking at working with consortiums, working with coordination, and working on the ground, that all of these issues roll into one. So thank you for kind of pointing that out and then teasing out, where we can best move forward. I would just ask Tom if he'd like to say anything on that. Before we move on, the timing is fantastic, but I'll just give you one more opportunity for any other comments. Tom?
Thanks for that. I think in terms of, I talked a little bit about the metrics that we're collecting in terms of pre and post tests. And again, this is one of the challenges where we don't have a presence. It's a lot harder to measure impact. But we're gathering data in a lot of, and keep in mind, and I was just answering a gender question that almost has the same answer, but the training program is one aspect of our response. And in other aspects, we have more social work, we have more individual counseling, and it's a lot easier to get that impact measurement. But this is one of the challenges because of the scope of what we're trying to accomplish. We don't have very good impact data beyond the quite standard educational knowledge improvement metrics that we're collecting.
Yeah, thank you for that. And I think in the future, what this real-time data collection and real-time learning is something that on the core group we're looking at, and we're looking at trying to bring that to the forefront as well. So thank you both, to Carla and Tom, very much for your presentations and for the discussion. What I'd like to do now is ask David if he could share the results of the poll. David, over to you.
Yeah, Julie. Thanks to those who replied to the poll. I'm sharing with you the responses. You should be able to see them on the chat box. But most of the people who responded say that what is the greatest need right now in the COVID-19 response is technical training for frontline our community health workers.
Thank you, David. Thank you so much for those of you who participated in the poll too. We appreciate your thoughts very much. So now what I'd like to do is I'd like to continue on, and I would like to invite Umbretta Baggio to share her presentation with us now. Over to you, Umbretta. Umbretta, I think we need you to unmute. Thank you.
I didn't have, sorry, yeah, thanks. I didn't have the presentation right, so I do have just a second. Okay, so hi everybody. My name is Umbretta Baggio. I work for the Red Cross and Red Crescent, the International Federation. And I'll take you now to the Risk Communication Committee engagement side of things. Like Carla, I'm an expert in that, and what I'll share with you is more our response to COVID from the community engagement standpoint and the evidence we use to really inform our strategy. I want to start with paying tribute to the Red Cross and Red Crescent volunteers today because it's Red Crescent Red Cross Day. And they deserve all our clapping for the work they do and for all the health workers work around the world. So moving on. So the content of the presentation will be around the context. I want to zoom in into what's happening now, our community engagement work and how it is changing and evolving over time. 6 lessons we learn over time. I've been engaged for 2 years in the Ebola response in DRC, so great lessons there. A bit around the solutions, although I wouldn't call them solutions because no one has really the silver lining to this massive challenge that we have in front of us, and then some of the resources we have. So zooming in into the context that we're dealing in. Something we've never experienced before, right? All of us. So we're dealing with a multi-centered pandemic. So numerous epidemics around the world, which are very different from Africa to Europe, to the Americas, to Asia. All of them are different contexts, different phases. But what is common to all of this is that the whole focus is on a localized response. We cannot travel, there is no international team traveling in, so it's all down really to localized response, the local actors' capacity to really work hand in hand with the government to face this response, to face this epidemic. Two, this is fundamentally different from anything we've ever faced before. But just to say, from the community engagement point of view, we're facing something where we have is easily spread, the virus is deadly, we have no diagnostic, no drug, no vaccine, and a very long tail, which means is an epidemic that has an exponential growth pattern, but halving or reducing the number of cases in this epidemic take as long, like in Italy, as like 30 to 40 days. So it takes 5 days, less than a week to doubling, and then more days to really go down to controlling the epidemic. And this is very important for the people to understand and know how this can be such a long protracted crisis. Third is a point I want to make here around public health and social measures. These measures, although social measures we're asking people to adhere to, they're difficult. They're all difficult behaviors. And we've experienced over and over in epidemics, and lately in Ebola, that unless this is discussed with the people understand them, and they agree also on how they will implement those measures together with the government, unless we do that, people won't really be on our side, and risk that is happening already in many countries is explosion of violence. This is connected, of course, to the socioeconomic impact of what's happening right now in many countries, African countries. So let's have a look at how our network is working on that. So health is really our core business. And you can see that out of 192 national societies, the majority is working in health response. From the community engagement standpoint, again, the majority is really working on addressing misinformation, community feedback, which I'll touch upon, but also stigma prevention, which has been at the very beginning really a big part of our work. It's a picture of how we work, and this is important because this is where we're becoming creative. So in a movement restrictions type of environment, we need to rely on different points of contact, volunteers with the people we're serving. And we have numerous points of entry to interact with them. Besides, of course, using technology, we do interact with the people when we do the social support to the elderly, we bring the food to the elderly, we do interact with them in the screening, we do interact with them in the testing, we do interact with them in the hotlines. So although we don't have the capacity anymore to have as many volunteers as we used to have in the communities, we have many entry points, and this is important to say. So moving into the community engagement side of things. And this is, again, coming from lots of learning from the previous epidemics. Trust is really at the center of what we do. And trust means that it's really around understanding what people are thinking, what power dynamics are going on, what knowledge they have, what misperceptions they have, understanding and starting from that point to engage them. I think there are some people that are having the mic open. Let me know if there is any issue. So providing that information based on what knowledge is there is really important for us. The biggest experience is that people are dynamic. Their knowledge is dynamic. Their behavior is changed. Their questions change. It's very important to have a pulse of where people are at every single stage. And so the feedback part for us has become such a central piece of our work. This is around understanding what people need and perceive of the work that we do in general, but the work that other partners do. And then really working with them and accompanying them in finding those solutions. And I'll come back to this because this is really important and is the shift we want to make from this obsession on the messages to move away and actually start with the listening. So all the trainings we do is, and the one we will be doing now from distance and the e-learning is around getting the volunteers to start by asking questions rather than throwing knowledge out at the communities. So move into some of the key findings or the key lessons learned. And again, I've been engaged for the past 2 years into the Ebola response, and this comes also from my experience in West Africa. But the important part here is really to start where the communities are. When I say that, I mean also communities are, not only countries are different, of course, but communities in Congo, in communities in Goma, and communities in Butembo, which are 2 centers of the epidemic, were really, really different, and they had different perceptions, different behaviors, different knowledge. So it's very important to start where they are and have our community engagement approach. Again, moving away from throwing messages at people, but more starting with that listening part. The two-way trust. So this is another important lesson. There's been a lot of narrative around how much we need to make sure that we gain that the people on the ground, the communities trust us. But unless we start trusting them, this trust won't be there. And this is very important in the sense that in the work that we do around the community feedback, unless we take it very seriously, the suggestions, the questions, and the concerns of the people, and we demonstrate that we're responding to them, we really value their suggestions. So there is this two-way trust. We're not going to be able to really work in partnership with the communities. Communities are dynamic. Also, when we do, we've experienced many times doing a survey at the very beginning of the project or our approach, and then we've never asked them again. Communities, they change so rapidly, especially in epidemics, where fear and anxiety is really defining the way I behave, and this fear and risk perception will change over time. So they change very rapidly. That's why it's very important. Again, I go back to the evidence. It's very important that this evidence in real time, which means it's not that I do a survey this month and then I think well, another 2 months and then in the epidemic I'll come back and do another survey. We need to be more agile in the way we operate, and this is our biggest learning coming from epidemics. It's not about delivering a service for sure. Again, COVID is a different situation, but in Ebola we had all the services available, the treatment, the vaccination, the facilities, the people, but we're not using the services for many different reasons. This one is going as local as possible, and you'll ask me, how do you do that now? Of course, because we can't move, but again, we have a network of local organizations, and this local organization is supported where they are from the distance the way we can, and this is happening and can happen, as Tom was illustrating with the training. The last one I have, which is very much in my experience, in my mind, there is an overarching obsession with rumors. Rumors is not the only thing you need to be obsessed with. You need to be obsessed with the type of questions that people are asking, be it online or offline. Obsessed with the suggestions they make so that you can change the way we operate. I'll move on, and I want to give you some examples. So we are now in situations where the challenging situation is a decreasing face-to-face interaction, misinformation and rumors, which is part of our evidence, is valuable, but it is not the only thing. There is, WHO call it an infodemic, and we're dealing with the entire world, so it's a very challenging environment. Some of the solutions that we've been working on, and again, then I give you also some more insights into the feedback, which is really the evidence we're talking about, and a bit of the innovation we're bringing in, which is not a tech innovation, but is a very low tech, in fact, innovation. So, citizens, the almost real-time information that we're able to get through the feedback system we have established in different countries. We've experienced that in the DRC, and I can share more information about that. But now we are rolling it out in many countries in Africa, but also in Asia. So this is valuable data that is coming in. Is based on face-to-face conversations when we can do that, but also social media scanning, hotlines. Our like Tetale Red Cross as a very popular hotline in Italy. They get all this feedback from people. This is valuable data, but it's also we also roll out quick surveys at different perception surveys at different points in time. All this data combined with other organizations, it should be really our listening and define the way it should give us a direction. And it's very, very important that we spend time analyzing that data. The other change was made really, and the focus we've had with the COVID response has been around engaging key influencers. Another learning that has come strongly from Ebola, sometimes through the violence and attack. People want their people to be speaking to them. They don't want us or the big organizations to be speaking to them. In fact, we're not the most trusted people overall, meaning the global organizations. The people that are trusted are the doctors, the leaders, the social influencer that can be somebody sitting in the capital city or in another province. So there is a campaign we're doing now with an organization we're working with that mobilizes key influencers in different countries, again, with very simple content that they produce themselves with our support. This is done globally, but then locally, I mean, you can do that, of course, through other sources. It's about motivating also social responsibility and community citizens' actions. This is very important. And the last part is around making sure that we focus on planning together with the communities. And this is one of the key learning for us. Since I have a short time, I'll just focus on this. So what's happening now is that our innovation, and when I say about this question about what creative things have you done, we haven't done big tech solutions, but what we've done, we've taken the feedback work to the next level. So we have now, thankfully last week, and 24 African national societies reporting on community feedback. This is offline feedback that we're listening from the communities, be it through face-to-face. We use Kobo as a way to share this information with the regional level, or it can be through an Excel sheet. But we have a coding system that is consistent across the different national societies in Africa, but also in Asia. Coding meaning that I'm able to extrapolate the same kind of categories. And for example, we know that there is, and you can see that there is lots of questions around who can be affected by the virus, but also a lot of mistrust of responders in this, and we extrapolate key content coming from these categories. So we have we take unstructured data and we structure them, and this we've done in countries, but now we are doing the trend analysis across different countries, and this we're making it available to many organizations, and in fact working with organizations like Ready, World Vision, and others to really find ways to address this back.
Thank you, Brada. May I please ask you to wrap up to make your final points? Thank you kindly.
Yeah. So I'll share just, I have a slide with all the resources, including the feedback mechanisms, and guidance, and just to say that moving now to a less face-to-face kind of interaction has been possible, as I said, through different entry points, innovations also, because we have platforms like in the Philippines for Filipinos abroad, which is called the Virtual Volunteer, where we share content, and we use extensively the radio approaches. If you need any of this guidance, it is available on these links, which are available already on the Ready Network, and then I added there also the links to the coordination systems of the interagency from the different regions, where you can find great material which is applicable more to that region. I'll stop there, and you'll have my contacts at the end in the online. Thanks so much.
Thank you kindly, Brada, for sharing your afternoon with us. And thank you also for including these very important resources. What I would like to do, we're getting some great questions. I'm holding those questions. I would like to just ask you to stick with us, Umbrella, because we have some great questions for you. But I'd like to move on now to Eric, James, and Claire Travers for your 10-minute presentation. Thank you both. Please, the floor is yours.
Thank you, Julie, and hello, everyone. It's a real pleasure to be part of this group. I'm looking at the names, and it's great to be amongst the choir. So those of you who are not familiar with Field Ready, we're a fairly young organization. So I'll just mention that we have a presence in about 7 countries, Syria, Iraq, Nepal, Bangladesh, a regional program in the Pacific, and a small program in Kenya as well. We're funded by some of the normal names, OFDA, DFID, DFAT, and so on, and partnered with some of the organizations. And we're always looking for more, so I hope you find this presentation interesting. I want to start by drawing attention to our logo there. There's a small bucket. It's not just any bucket, though. It's one that's originally designed by Oxfam, is meant to be used in places where there's forced displacement or other emergencies. And typically every family gets one, as you probably know. And several years ago, I was in Nepal, where there was flooding in the south of the country, and tens of thousands of these buckets were needed. And unfortunately, let me see if the tech works. Unfortunately, this is the journey that bucket would have to take. They're made in only a couple places in the world, and at this time it was in Pakistan. They're shipped to places, central depots like the one in Oxford in the UK, and then shipped back through places like Dubai, and then onward to the affected country. And that's not even the last mile. The journey is long, expensive, and cumbersome. And this doesn't just affect the WASH sector, of course. It affects all the other sectors, whether it's health and all the things that people need around health, and we're especially seeing that with the COVID response. Shelter, NFIs, virtually every sector, even things like search and rescue, are really hamstrung by this sort of problem that we have with supply chains everywhere. And the reality is that most emergency aid is spent on these logistics. And so it is really the big giant elephant room that cuts across all sectors. And Field Ready is dedicated to changing that situation. Fortunately, this is what we're facing, this sort of technical diagram, actually from my first book. All these different gates that materials have to pass through is a chance for delay, for bureaucracy, for further expense, and so on. And so the transformation that we're working towards is moving manufacturing to where communities and affected people are. We're doing that through local manufacturing. And not just local manufacturing making things where they're needed, but also working on distributed manufacturing, connected what already exists on the ground and enhancing that capability so that we don't have the kind of delays that we've been seeing. So the impact of this is actually huge. We're seeing massive reductions in costs, much quicker procurement times going from weeks and months typically to hours and days. And really local support, livelihoods are supported in businesses. But more importantly, as humanitarians, we see that more lives can be saved, suffering can be reduced, and resilience itself can be supported. So we believe that by making things locally, we can make the world a better place. I want to give you a couple quick examples. So health, there's quite a bit we can do. And really our first project started with this small umbilical cord clamp. The baby on the left is like any typical baby should have, every brand new baby should receive one of these umbilical cord clamps. And unfortunately, in many countries, Haiti, for example, where we got our start, they were using things like old shoelaces, the one that you see there in the bottom center. But we found we could actually make them locally just by using the technologies that we have available today. And not just little simple things like umbilical cord clamps. We can make replacement parts. We can make things that fix very expensive equipment, different types of supplies that are needed, and so on, really across the sector there. Livelihoods, it's a very quick story. This is Mr. KC from Nepal. he had a vision for a new type of cook stove, and that's what you see in the upper left-hand corner. But he really couldn't make it. By working with us, he was able to realize his design. We helped him make several thousand in the first year, and now he's received orders of over 200,000. So now he has a viable business, and it's making a huge difference in Nepal. And we're not just doing that there, we're also seeing how we can support livelihoods, and we have a program for youth in Iraq where we're supporting maker spaces across the country there. Wash, there's all sorts of things we can do with wash. And the picture on the left, you see a leaky pipe, and on the right, you see the replacement part we created. And where did we make that? Right there in the field, just within a couple hours. And this is quite interesting as well. We're really only limited by the creativity that we have. And I think any parent knows that getting kids to wash their hands is quite a challenge. So we've embedded soap with toys to encourage hand washing. We did this with Save the Children. It was studied and found that there was a 4-fold increase in hand washing, and we're quite proud of that. And we're rolling that out to other countries as we speak. And we're not just doing these small things, but we're also doing mass production. So these are latrine slabs uniquely designed in Pacific, and using techniques that are there on the ground. We're also finally making this bucket that we dreamed about several years ago, and those are being distributing as we speak to Harold, Tropical Cyclone Harold that hit Vanuatu not long ago. So that's a very quick overview of what we're doing. I'm going to hand this over to Claire, who's going to talk more about the COVID response that we're doing in these things. Claire, over to you. Let me know if you can.
I think you're still going to remain in charge of the slide, so I'll tell you when to change. Yeah, so the focus of my few minutes is just going to be on 2 countries in which Field Ready is responding to COVID-19. And we're responding to the demand for personal protective equipment and health and hygiene solutions through these distributed localized manufactured supply. As the supply chains broke down in the early months of the pandemic, the provision of PPE and health solutions was pretty severely affected, but for Field Ready, we were kind of perfectly positioned to activate local manufacturing supply chains. And now that the international supply chains are beginning to recover, we're really interested in ensuring that the local manufacturers remain included. So I'm going to focus on Nepal and Bangladesh, but I think it is important to note that Field Ready is also responding across the Pacific, the Middle East, Eastern Africa, and in the USA. And I'm focusing on Bangladesh and Nepal because I've just come back from deployment there. So in both countries, Field Ready is experiencing some challenges, but basically we are, no, you can move to the next slide, thank you, Eric. In Nepal, we've been operational since 2015 when we were responding to the earthquake. And we've fostered, during the last 5 years, an ecosystem of makers that have the skills and tools to digitally manufacture basically anything that they want. So in 2019 alone, we trained over 600 individuals in digital design. And over the last 5 years, we've seen supply chains for the necessary raw materials to do that digital manufacturing. That has independently been cultivated through the demonstrated value of the products that they made. In 2017, Ram, who you can see on the left there, he started the Forum of Digital Manufacturing. And since the beginning of this COVID pandemic, the makers in Nepal have independently responded. They have been making items and delivering. To date, I got my updates today, they've made 11,000 face shields, 8,500 of which have been delivered to clients and hospitals directly. 5,800 PPE gowns have been made and delivered, and they have just finalized the mold for goggles. Whereas in Bangladesh, I think we can go to the next slide, please. Field Ready has been only operational since the end of last year. And whilst the manufacturing capacity in Bangladesh is obviously existent, it's in a very large scale. It's predominantly in specialized factories that have corporate production runs for specific products. And what we found is that this type of manufacturing culture is not necessarily easy to dynamically refocus into the manufacture of a needed item. So what we've done in Bangladesh is we've engaged 2 fab labs in universities that have been equipped by the World Bank, as well as private sector small-scale design labs, and we're overseeing the manufacture of 5,000 face shields. and 340 goggles to date for NGO frontline staff. And here you can see some iterations of different types of face shields, all made locally within, I think, maybe 3 or 4 hours each, I should say. So this has incorporated basically a very accelerated capacity building project that we were already planning to run in Bangladesh. Both of these responses are supported at a global level by a COVID technical team, which are testing the designs for digital manufacturing for all of the designs that we have pushed out. During the beginning of this dynamic, we saw a number of designs pop up for PPE and also for ventilators, for incubation boxes, you name it. There was lots of open source designs floating around. And the challenge is you can't just pluck these designs off and send them to people to make. They have to ensure that they are genuine, applicable, documented, and safe. So this is one of our major issues for which we put together a technical team of engineers who can, with the support from our field offices, test the different designs and ensure that they are appropriate and relevant. This was also an issue because the designs that were needed changed from place to place. So the PPE zone I mentioned that we used in one response would have to be tailored to the new size of the primary user in another response. I think you can go to the last slide, please, Eric. Oh, no, I forgot about this slide. Brilliant. Here you can see an elbow tap. So this took about 12 hours from the concept of our partner to the actual installation, which you can see here, installed by Pradita, who's our project lead in Nepal. And these are now available for 3D printing globally. They're an open source design, and obviously they work not just on taps, but you could also use these on door handles as well. So this was quite a nice example of how quick that lead time can be. So next slide, please. The lessons learned really of this, we've spoken a lot about the power of remote management, but also remote capacity building, and for us as well, the capacity mapping. So I won't go into that as much as I was planning. But what we're really seeing is the potential for regional collaboration. We as Feel Ready have been looking at countries like within the country for a long period of time to establish those makers. But as we can see between Nepal and Bangladesh, where there is already a maker ecosystem, the lead time and the production runs can be smaller and larger respectively. So a smaller lead time and much larger amounts of products being produced. There's nothing to necessarily stop that from being expanded to a regional collaboration, say, going from Nepal to Bangladesh, now that some of the borders are beginning to reopen. And the final lesson then was the need to engage the clusters or whichever organization or organizational hub is involved with the procurement for NGOs and frontline workers. At the moment, we have realized that this is a little bit ad hoc, and one of the things that Feel Ready is moving into is ensuring that the quality testing and the necessary documentation is done for all locally made designs. I think I'll leave it there as I believe I'm at time, and I'll hand it back to you, Julie. Thank you.
Oh, thank you so much, and welcome back from your deployment. So happy to have you, Claire. We have some great questions. Now, first of all, we have another poll that we have put in the chat box, and we have some great questions for Umbretta. I'll be pulling Tom back in, but before we do, I actually have a question for Field Ready. You've talked a little bit about the donors, but could you talk just briefly about the startup costs for manufacturing? Over.
Yeah, good question. Well, it's variable. It's sort of how long's a piece of string. In many countries, we're already established there, and to go to the sort of products that we displayed here are fairly minimal. Staff time, some production costs. Some of the more complicated things, of course, there's longer timelines, more materials, more trials and failures. A key part of doing any design right is co-creation with people, with the end user, getting enough feedback so that the good ideas are incorporated into the final design. All that can take further time. Generally, though, to rapidly make a prototype, again, some of the examples you saw here are really pretty minimal. And the overall costs that we talked about have been measured. We're seeing about an average 50% reduction in cost. So really, we'd have to break it down by each item to give a precise answer, but I hope that helps give you a sense of the capability of this approach.
Yeah, I think that that's really helpful, Eric, just to kind of get because it's so new. The other thing that was striking is was the soap and how creative and fun that was. Claire, since you've just come back in the field, can you talk about where did that idea originated and how it came to fruition? Over.
Yeah, sure. So this was an idea that was, as Eric mentioned, initially implemented by Save the Children in Iraq refugee camps, I believe, in partnership with the London School of Tropical Hygiene Medicine, which is a name I always get incorrect, I'm sure. We are now replicating this in Bangladesh, which fits quite nicely with my part of the presentation. Apart from just making PPE equipment, we are rolling this out to be provided to the communities in the camps, both the host communities and the camps communities, in partnership with BRAC and World Vision. So this has really come from I would say quite an academic place, but it's found a lot of traction around the world. We're really eager to see it being implemented in the camp context, especially.
Oh, thank you for that. Now, Umbretta, if you could ready your mic, I have a couple of questions for you. Thank you so much for ready so much. Umbretta, the question that I have is, let me just read it for you, if I may.
Yes.
How can we generally address the risk of violence? Oh, excuse me. Sorry. That's not it. Excuse me. In terms of building trust, do you look at engagement with communities from a gender perspective, as this is critical to really understand social nuances and build an effective response? Can you expand on that a bit? Thank you.
Yeah, sure. Yeah, definitely. I mean, I was about to respond in the chat, but it's better live. We do have a gender lens for sure. And I think the focus has gone really into understanding the sociocultural dynamics that are going on in the communities. And this is where we're putting more and more our efforts in this rapid assessments, rapid understandings, especially in emergency situations. This rapid scanning of the power dynamics is very important. The experience we've had is that in epidemics, we really need work hand in hand with other organizations on the ground, and hence, I mean, really returning to the point of coordination, because the Red Cross Red Crescent, we can bring to the table some data that help us in understanding this dynamics and how we can address them in our community engagement approaches. But we really need also the social science experts to help us with more research on that, which is what has happened a lot in Congo, for example, where we've been really working hand in hand with the social science group that was available and supporting the response overall to understand health-seeking behaviors and the gender dimension of that, which has been really an important learning, and also from the engagement standpoint, the decision-making power and who takes decision in the communities. And so definitely, I mean, in short, it's very much part of the evidence we need to use for making decisions and strategies. Over.
Oh, thank you so much. And if I may, Umbretta, I have one other question, and this actually ties into a webinar that was done yesterday for the PERC PERC report within the African context. And I wanted to just state that recent research suggests that while many people see a threat of COVID within their own country, they don't have the same levels of corresponding risk to their personal lives. And I was wondering if you could please speak to this issue and how it affects your work. Over.
So this is, I think this is the data that is coming out of CDC Africa together with other partners, right? So it's it's about Africa. and Judy, if I'm not mistaken. So there is really amazing data that has come out a week ago around how the risk perception, the individual risk perception is not very high. So what it means for us is that if I don't fear for myself and my family, chances are that I won't follow the recommended social measures and preventative behaviors that are recommended to me, because I don't fear that this virus will have any effect on me and my family. So what it means for us, and this is where, again, I go back to that fact that I told you about. For us, it's very important. So these surveys, they give you the bigger picture. Is a set of questions with close answers, give you a bit the picture of where people are in certain regions or countries. What we need is also more granular data. Is why do not people feel at risk? And one of the things that is coming out of our data is that actually overall across many African countries, there is a perception that this virus is not attacking Africans. That is more a virus of the rich people, of the white people. So it means that as an African person in a given country, I don't fear that, because my perception is that it will affect another person, not me. So it's very important to go down to the more granular data, and this is what we do, and understand and make that content available to the local organizations for establishing this dialogue around very specific things. And this content is available to other partner organizations for working in their with their membership. So I think the key here, when we have such a big challenge, is really to join efforts with many others, from the UN to other international partners, make sure that we have a coherent approach to engagement and understand at any given time what we want to say and what kind of focus we want to have for in the dialogue with people, be it online, with events or in different ways.
That's great. Thank you. We have a few minutes left, so I just wanted to put one more question out. And that is, we had a question about how we can generally address the risk of violence associated with inadequate palliatives, PPE, long waiting time for results, unemployment, and other social support issues. And I think keeping in line with how we understand that there are grand challenges before us, what could be some creative solutions that anyone might, of the presenters might like to bring to the table or to the screen, if you will, in terms of how we can proactively address some of these greatest challenges. I'll just like to open it up if anyone would like to comment.
Hey, this is Tom from Project Hope, and I realize my camera's blocked. There we are. You know, I think one of the things, and I've mentioned this in the answers to a couple of questions, but one of the ways that we're rethinking business as usual to address a lot of the challenges and to even develop, not only address the issues, but structure ourselves to address the issues, is we really have to decentralize, and we really have to figure out, and I thought the local production is just brilliant. Just probably the best example of this that I've seen. You know, we have to figure out how to move our centers of humanitarianism from the U.S. and Europe, and actually build more capacity in areas where we actually work. And I think that you know, especially in the age of travel restrictions, this is quickly going to become not opt in. This is mandatory right now. And this is really just showing, I think, potentially a vulnerability. And there's a lot of innovation around how to do this remotely, but also, how to creatively structure organizations and programs to accomplish this. But that is really, the lesson that me personally, I'm taking away from this.
Yes, thank you, Tom. And I just want to share that in my notes, the remote management piece came up quite a bit. So I thank you all for sharing those creative solutions. I thank you all for being very positive and proactive in a very difficult time. And I'm very appreciative of all of the comments and the engagement of the presenters and the participants. So for the last few minutes, what we're going to do is David is going to share with us, I think he has shared with us the polling, so I would just like to make one comment, and then I'd like to hand it over to David, who has a pretty exciting announcement for all of the participants and presenters. But the only thing I'd like to mention about the polling is if you look into the polling tab on the chat box, we had asked you about the different groups that you're working with. And what's interesting is we see that there we have a lot of work to do, I think, to focus. We have a lot of work to focus more clearly and target more precisely on people with special needs, populations with special needs. And I encourage us all to look at ways that we can do that in the future. So now what I'd like to do is I'd like to ask David if he could share with us the information that he has, and then wonderful, and then I will close the call on time today. David?
Yeah, thank you so much, Julie. First about the poll, thank you so much for replying. Most people reply that they are working with pregnant or lactating women, which is very interesting. Followed closely by children and adolescents, as well as refugees and displaced populations. So we have been talking about this resource matching platform on the chat box. Core Group with Needs List have partnered to respond to the COVID-19 issue of resources, commodities, and knowledge management, and we are launching this partnership with the resource matching platform for COVID-19. We will be hosting an information session this week, and I am sharing with you the link to register now on the chat box. So if you would like to know more about what this initiative is and how you can benefit, and also your organizations and your groups, please register on the link that I just shared on the chat box, and we will look forward to connecting with you on May 14th. Thanks, Julie.
Thank you, David. And I just on behalf of Core Group, if there's anybody else on the team that wants to say anything, I'll just take a breath here and my final comment will be then that we appreciate all of the presentations, especially the great insights and the resources shared. We always like to feature resources at the end of the week to let you know how rich our library is, and we encourage you to share your own resources here. With that, I just want to, I think we have one more slide just to say thank you. So I want to thank you all for your great participation. It's been such a great morning and afternoon all over the world with everyone who's joined. Thank you for being such wonderful partners and members and partners of Core Group. I wish you all a great day, and thank you again to our wonderful presenters. We'll sign off now officially and wish you, we'll see you back next week.
Thank you so much, Julie.
Thank you, Claire.
Thank you, everyone. Thanks, Julie,
Thank you
David.
so much, Eric. Lovely to have you.
Yeah, likewise. Thanks.